Spine surgery for the last 30 years has made things too complex. And that's when I started down this journey 30 years ago. Spine 30 in the last 30 years has made things too complex. Everything's become a fusion. Every pathology is a nail for the hammer, the fusion hammer. Okay? When you break it down for patients, when you slow it down, when you draw it out, literally or figuratively, they get it. They understand the need to preserve motion. They see the consequence. They see adjacent segment degeneration. And they look at these discs and they look at these other techniques we use, not as devices, but instead as a worldview. You know, it's a commitment to longevity, a commitment to biomechanics, and a commitment to living normally.
Welcome back to the Spine Pod. I'm Courtney Schutze. I'm here with my co-host Brady Riesgraf, and we are in Coeur d'Alene, Idaho, and we sat down with Dr. Jeff Larson, and he let us sit in his amazing home.
We did. It was absolutely incredible. You know, it's so much fun when we get to spend time with the surgeons too, and we got to go to an amazing dinner with him and his fiance, and Bree runs the social media. Like, it's so fun to meet the team that's behind it, right? But I think we truly resonate with his philosophy on care, right? Which is this holistic care aimed at improving patient outcomes, right? Everything he does is aimed at improving patient outcomes. And it's so much fun to sit down with someone that has that much passion and drive to do that sort of thing.
Absolutely. I loved his philosophy on patient first. And also you can just tell from the person he is, getting to spend time with him and Megan. And he is a person that gives 115% to everything that he does. And that's the kind of surgeon you want. You want a surgeon who is so laser focused on you and your care. And so it was great to be able to share him with our audience.
And dialed into the research too, right? Because you have to pay attention to what came before and what is to come, right? And he's right in the intersection of all that. He does everything, right? He's a surgeon, he's an athlete, he's a father.
He's a pilot.
He's a pilot, right? Not the first time. And he's an inventor too, right? Yep. And so everything he's doing is he's kind of like making this combination, him and his team, right? To improve patient care. And it's so much fun when we get to do that and then share that with our audience. And he has so many good nuggets and so many good stories that we get to share. And I think it was so much fun to be able to sit down with him.
I agree. And this is a beautiful place to do it. And he gets travel patients. So, you know, he's available for anyone, anywhere. And if I'm going to come get, you know, an opinion, I would not be mad doing it in Coeur d'Alene.
No, absolutely not. All. But if you don't, he has so much education material out there, right? And he spends so much time pushing that forward, educating patients, educating other surgeons, right, on technologies. And I think that's so powerful and impactful.
Absolutely. So enjoy this episode with Dr. Jeff Larson.
Dr. Larson, thank you so much for taking us in your home today. This is beautiful. It's fantastic. We're sitting right by the river and we get to sit down here. This is amazing. Thank you so much for having us.
Courtney, Brady, you're welcome. Welcome to my home.
We're super, super excited. You know, I think a lot of people know you. You've built this social media empire here in Coeur d'Alene, which is really, really cool. You know, for the people that don't know you, we're sitting down with a neurosurgeon, a motion preservation specialist at CDA, Spine and Brain, which is incredible. You've built this amazing practice. You know, you've done so much research, 60 publications, probably 100 more presentations at all the big meetings that we go to, NAS and SMIS and AANS. And I think most importantly, you have a dog that is a social media star, Oliver, who's joining us today, which is really, really, really sweet.
The director of compassion.
The director of compassion. That's super sweet.
We had the opportunity to go to dinner with you and Megan last night, and we got to meet Oliver yesterday, and he is really the director of compassion.
He is, isn't he? I
mean, the best time.
He's kind of a part George Clooney, part Labradoodle.
That's a high
Australian
compliment.
Labradoodle, right?
I want him to come home with me.
Yeah, I'm sure he'd enjoy that.
That's
He
so
seemed to like you,
fantastic.
Courtney.
Well, we're glad he's joining us. Thank you so much. We got to spend, like Courtney said, an incredible time with you last night and your team. And it was so much fun. And we're really excited to jump into this one.
Before we do, I like that. Before we talk about discs and fusion and motion preservation, I'd like to talk to you about something that happened to me this week. Okay?
Let's hear it.
I'm in a waiting room with my fiance, Megan, and Dwayne's wife, Lee. And Dwayne, my buddy Dwayne, is in the operating room having surgery. He's having an extracranial to intracranial bypass surgery, okay? To help reconstruct a cerebral aneurysm. Not a surgery that you just gloss over, okay? In walks a neurosurgeon, Michael Lawton, MD, probably the greatest living cerebrovascular surgeon today. Okay? There he is in his scrubs, a fleece, and a marking pen, like he's about to sign a painting. And he goes up to a whiteboard and he draws out the whole operation in about 30 seconds. A flow arc here, the aneurysm there, the inflow there, the bypass here, the clipping here, the reconceived, cerebral circulation. Clear, calm, and humble, no ego. And I thought about it, and that's really neurosurgery, spine surgery, surgery in general at its purest, taking something that is impossibly complex and making it understandable. And that's what I love about motion preservation. Okay? It's pure, it's purposeful, and it's precise. Spine surgery for the last 30 years has made things too complex. And that's when I started down this journey 30 years ago. Spine 30 in the last 30 years has made things too complex. Everything's become a fusion. Every pathology is a nail for the hammer, the fusion hammer, okay? When you break it down for patients, when you slow it down, when you draw it out, literally or figuratively, they get it. They understand the need to preserve motion. They see the consequence. They see adjacent segment degeneration. And they look at these discs and they look at these other techniques we use, not as devices, but instead as a worldview. It's a commitment to longevity, a commitment to biomechanics, and a commitment to living normally. So today, what I want to talk about is not only the devices, but my philosophy on giving patients their life back with the least surgical burden possible.
I think we're in a really exciting time in spine and patient care for that reason, right?
Yeah.
I think you have the accessibility of so many other perspectives, knowledge, and then the technology, which is improving, right? And we're moving and have moved into motion preservation. And now those motion preservation technologies and options are getting better too, right?
They
And
are.
more is coming. We like to start with kind of your journey into medicine. And I would love to hear what spurred that for you, the initial push that got you into medicine.
And my journey down this started, most people decide sometime. I'm one of the ones that decided when I was a kid that I was going to be a doctor. My father was an anesthesiologist, did critical care medicine, trained in Boston. He was in the Navy, lived around just a little bit. But ultimately, I wanted to go to school to be a biomedical engineer. I'm always scientifically oriented, just biomedicine. At the time, back then, the school that I wanted to go to was cost prohibitive. I was a local in Michigan, University of Michigan, not too bad. It was just a lot more economical for me, and I started going down this path of medicine. And my first thought was towards orthopedics. As athletic, as that kind of ortho bro thing, right? And then I was in a rowing program that led me to Cincinnati. Okay, that led me to Cincinnati. And there is where I met my mentor, John II, in neurosurgery. Started going down this path of cerebrovascular surgery. This is an aneurysm clip here that he gave me. Thank you, Dr. II. He's really, and he has a lot to do with what I'm doing here. He's a very practical thinking, take what's complex and make it simple, period. You be real. Dove into a rotation in neurosurgery and just switched automatically, met my mentor, but stayed in with some of the orthopedic spine at that time. There was an orthopedic surgeon that was reconstructing spines anteriorly. I just kind of paid attention, stayed in on that. But I got nervous in neurosurgery that I was going to get funneled down this path of neuro-oncology, which is great, but it wasn't my particular surgical interest. Okay. But it was another mentor there that said to me, Jeff, we just care that you can become an expert, and you've proven that. And if you can become an expert in this with your skills, you can do anything. So that's helped me each step of the way as I've moved into, I'm here in Coeur d'Alene, Idaho, probably the most distant place where you can do high-level neurosurgery, right? And I mean, there's more distant places, I'm sure, so don't take offense to that, but it's up there. Coeur d'Alene is kind of cool. It's sort of like if you took Lake Tahoe and Alaska and they had a baby.
That's a really good
It's kind of like
connection.
right here. You have this backcountry, you have this in country, you have this, it's toned down a little bit. It's toned down a bit, but I like it here. I moved here as I stepped along. You start giving up things that you're doing. I gave up cerebrovascular. I gave up the academics. I gave up, the bigger brain surgeries, moving to Coeur d'Alene, but started focusing on what I could do. Fine.
You simplified
it. And now motion preservation just made sense every which way but loose.
When we were driving yesterday, I was like, this reminds me a lot of Lake Tahoe. We were driving on the road, and that was exactly what I said.
It's kind of like Lake Tahoe 50 years ago.
Yeah. Before it got big.
But it's got its attractions. It certainly does. But yeah.
You talked about mentorship and your mentor and John too. Talk about your dad a little bit too, because him being an anesthesiologist, I mean, that plays a big role as well. Was that a big influential role in you getting into medicine?
Yeah,
as well?
it was. My dad was, he's not with us anymore, but he was a big influence on me always. I watched he trained in Boston at Mass General, and he was a critical care doctor. So he was always, in the ICU, he had the hours, he kind of had the hours of a surgeon, right? And so that, I knew there was no surprise in my era of training. We'd work 126-hour weeks. I don't think that happens anymore. You show up at 6 a.m. one day, hypothetically, you got to be ready at 6 a.m., which depending on how big your ICU is, you have to get there to be ready at 6 a.m. and you are officially off at 6 p.m. the next day on your every other night call schedule. And, but you don't get out at 6. That's just when the attendings start coming around to make their rounds. And so, that you just have to have the mentality. The real problem with every other night call is you miss half the good cases. If you can carry that on for 7 years, and you'll make it. It's good. It's changed now. It's a lot different now, I think, but it's how it was then. And I think some of the other guys you interviewed can attest to that, So, but growing up in the presence of somebody who took care of patients in a life and death situation. So, as I said, he's critical care. One of the first things you decide when you go to medical school, are you going to be a doctor or a surgeon, right? And if you're going to be a surgeon, are you going to be one that saves lives or makes them pretty or does something like that? I chose, you saw where my route went. And then, here I got spit out here in Coeur d'Alene, Idaho now, so many years later. So
seems like a good place to be spit out.
I like it.
So how does it all tie back in? So you go back to your training in Michigan, you're in Ann Arbor, and then you actually go get your master's at Wayne State in molecular genetics.
Yeah.
Was that a path that you wanted to go down? Is that a path that you wanted to integrate into orthopedics or neuro? Like, how did that fit in?
I loved science always. And the honest truth is I was rowing, and I was living in Windsor, Ontario, rowing at Detroit Boat Club, and I had to come up with what am I going to do for this time? Okay. So anyhow, I was at that time you could cross the border for 75 cents, pretend you had a girlfriend on the other side, and they let you go through. But now it's a lot different now, right?
Yeah.
Okay. So, but I did some extra schooling. I did I did molecular genetics at the time, and I think my first paper was sitting in a refrigerator for 24 hours. This would have been 1987, something like that. I was sitting in a refrigerator for 24 hours with an agar gel with DNA pieces in it, sending a current one way and then mechanically switching it over to the other way, trying to differentiate sizes of DNA for the PhD guy that was working on something there. So anyhow, but yeah, that was another great experience.
And then you trained in Cincinnati, and talk about the shift from going from Cincinnati, being in the Midwest around, Detroit and Michigan, and then making the move out here. Did you know that was what you wanted to do?
Oh yeah. I wanted, that was it. When I made one of the hardest decisions I made was talking to my mentor that I was not going to go into academics. I was destined to go to Lausanne to do some tumor research, maybe operate in Geneva, and then be in Boston, some academic situation. Okay. I wanted to move west. I mean, I wanted the big sky, I wanted the mountains. I wanted the life. I just wanted the life. I wanted to do my thing. I had all these other conflicts and I wanted to hone it in. And two had no problem with that. He put his hand on my shoulder and said, let's find you the right place. And we went after. Now, years later, my son is 16 years old, and we're skiing the Haute Route, which is a trek from Chamonix to Zermatt. 6 days, you're hiking on your skis, sleeping in huts. And
Wow.
I turned 50 in a Swiss hut. We made it over the Grand Combine, which was cool.
The way to turn 50.
That's the way to turn 50, right? And on the way back, from Zermatt to Geneva to fly home, we go through Lausanne. And my son's like, hey, Dad, were we going to like live here? You might have bogeyed this. And I said, no, listen, Clay, no. I can tell you right now, if I'd done that path, we'd be living in Boston and you'd be probably skateboarding right now instead of what we're doing here. So it's all balanced.
That's a good mix. It's
hard to find. I think especially, you know, we got to spend some good time with you yesterday and seeing how driven you are and that you do things at 115%, and figuring out how to have the balance of being so successful and driven in your career, and then also finding a place like this to live and find balance for family and life outside of that. I think a lot of times that can be just for anyone in general trying to figure out that balance, but being a surgeon, it can be really hard too. Where do you think you get that from?
I'm not sure. Maybe that was part of the subconscious thinking of don't go into academics, do this, hone in, move to Coeur d'Alene, that maybe that's part of it, is to try to secure that. I mean, my kids, my daughter's in New York, my son's in Seattle, but they still, this is home, and they love it. But it all worked out.
Yeah.
So it's working out. I don't have any, I told Dr. Tu, I said, listen, I'm not going to insult you and operate beyond he quit operating at age 78. So I said, I'll take it to 77. That's no problem. And that's it's a couple of decades away, right? But he then informed me, Jeff, they only made me have an assistant at 78, and I had to teach that guy everything. I kept going till 82. So I don't know if I can do that.
Yeah, it's a long ways.
Yeah, but listen, in this process, you hit your sweet spot. You find your sweet spot, and it would be a shame. You'd be cheating yourself, and you'd be cheating others, including your community, your patients, if you didn't keep it going.
Absolutely.
Yeah.
And you've got this beautiful practice that you've built here. We were able to go over there yesterday and see everything. I mean, incredible. And you kind of crossed the whole care continuum and I want to talk about all that, but I'd like to start with something that you had just noted on, which is your care philosophy, because I think it is different, and I think it's really impactful for patients. So can you talk about how you approach patient care and the things that you're paying attention to?
I mean, so patients come here. When patients come to see me, I think if they're sometimes it's a garage find, literally. I mean, it's like, okay, sometimes a guy will come in and be like, I'll ask, how did you get in here? And I'd be, it took me 6 weeks elsewhere, whatever. And I just got in, and I'm like, dude, I'm your Ferrari F40. I'm your garage find here. But, okay, let's go. You're in the door. Let's go. But honestly, it's the philosophy is to just provide a very thoughtful, ethical decision making. Do the right surgery, not the biggest surgery. Consider motion preservation whenever possible. Patient first versus payer first, and that's a big thing for sure. And treat the whole person. And I really wouldn't treat anybody like I wouldn't treat myself. I mean, you hone on the whole process. I think you're going to jump in my hyperbaric chamber later today, right? I applaud you on that. You're going to love it.
Yep.
I love it. It's fantastic. It's there's a side of my clinic that is designed towards that. It's called M3, mind matter method. The mind, I'm the mind behind it. The matter, or you're treating the mind, you're treating the matter. I choose the methods. They're all things that I've chosen for myself, and I just let my friends and patients use it as well. So hyperbaric being one of them.
Let's go back to that, because I think you have a good story of kind of what got you into that side of care as well, and adding that into your care continuum. How did that spur off of your surgical practice and building out M3?
Getting close to the age of old people. No. Honestly, there was a time when I had to get back, and it was like 2015, and I wanted to get back in the game. I called an old biking coach and asked him if there was a cool 10K. And he goes, "No, Jeff, there's no cool 10K. There's Boston." And I'm like, "Boston? I hate running." He goes, "I know, but you know the pain cave, and let's go try it out." And these guys are scientists. I mean, these guys measure. They can make you, they can take you apart and put you back together with training techniques. And I'm not talking like juice. I'm talking just the kind of training specific things you do. So if you're going to spend, and I chose these guys because you're going to spend an hour or 2 hours or 3 hours of your time doing something, why not do it properly? Do it properly. So I had the ability to do that. So he says, Boston. So I went out on some sunny day in Coeur d'Alene on some high school track, and I did the intervals he wanted me to do. He said, "Jeff, you can do this, man. You can do it." I said, "Okay," but I had a bum knee from 91. I had an ACL repair and meniscus and all that, name stuff. And so I went and connected with a sports medicine doctor in Coeur d'Alene who did some things for me. And I started thinking about what I do in preparation for training for Boston, because I needed it. I was willing to sacrifice to some extent, but like, did I want a total knee? No. And I ended up having to get one. Well, anyhow, I ended up staying whole with this guy, right? We just we didn't win some of these things like I talked about, and I never needed to do anything until fast forward a few years. I ran Boston. I qualified for it. And that was fun too. Showing up at Boston as a qualifier is super cool. I maybe didn't look like a qualifier. They funneled me into the corporate line kind of thing, And when they figured out I was a qualifier, whole different program.
Really?
There you go. It's super cool, right? And then I did it, finished it, and that was fun too. And I'm one and done with that, though. I'll be a volunteer there sometime. But I did no problem with my knee until 3 years later. I'm hanging out in Moab with my brothers doing a half marathon, and what made it a half was you had to cross the river, but it was more than a river crossing. You had to run down this river, and there's no bueno, man. That was not fun. So we're trying to cheat it, kind of running on the side, and I'm running on the side, and I fall off, and I hear my good knee pop, and I land in the water, and I don't know what hurt more, is the knee, popping, or the young lady coming up and asking me, "Are you okay, sir?" Which only drove me to like run faster and not let her get ahead of me, right? And so my knee I hurt it. I had named issues with it, and ski season was coming up, and saw an orthopedic surgeon who confirmed stability, but the MRI showed problems, and I just took the same, kind of non-operative path to try to take this and that. Then you saw my pulsar electromagnetic field, my hyperbaric oxygen chamber, my red light bed, some of the other nuances we won't talk about here in my office.
It's really impressive. I think one of the things we talk about a lot is this functional medicine and holistic medicine. And it's clear your office. I mean, it's funny, you come in and on one side, you've got your M3 clinic, and then on the other side, you've got your practice, right? And your clinic and everything like that. It's really impressive. I want to go back. You've been doing this for a long time, right? You've been practicing for 30 years now and all this experience. How has your mindset changed over time as you look at motion preservation and devices that have come out? Because you were kind of on that initial stage in, the 2003 to 2006 phase when these discs were coming out, right? You got your first lumbar disc, you got the first cervical disc. And can you talk about what it was like then and how it's shaped since then?
Sure. And, I think we can start with some of the changes in other devices like fusion devices. I came out of my residency in 97, and at that time, cervical fusion was making evolution. Okay, cervical fusion, you go in, you decompress, you do the anterior cervical discectomy. And actually, my training, it was still kind of half and half. Some would just do the anterior cervical discectomy without stabilization. Others would do the stabilization, and the stabilization evolved. And in this evolution, there was first autograft, taking a hip graft. Then there was plating with that. And then there was allogenic, allografts that you'd get, and you'd at first have to get a donor bone and carve it all up to shape it, do a little. And that was kind of fun, actually, to kind of do some architectural things in there. That was good. But then companies got involved with their plates and adding to it the the inner body devices, which started out as allograft bone, allogenic bone, structural bone, and then went into different shape cages. Okay, and then at the same time, we're all in the background. You start hearing about what's happening in Europe. You start hearing about these discs, artificial discs coming, right? So I wasn't part of the studies, but as soon as they became available, I jumped onto it. And by that time, I had moved to Idaho. And what the preceding years, maybe 2003 to 2006, all of us, anybody who was practicing then doing anterior cervical work, were saving patients for disc arthroplasty. We were waiting. We were saving patients for disc arthroplasty. At the same time, my mind is going and I'm kind of drawing art about how I would do this, things I would do, other options, because it still seems like a big procedure, right? But then it gets released, disc arthroplasty gets released, and we're landlocked by the insurance company. Okay? And you can see this to a certain extent. You can see everybody needs to understand the FDA and the insurance company are two different things. The FDA has their criteria to show safety and efficacy. The insurance writers, the insurance people who sign the front of checks at the insurance companies, have their criteria too. And I personally think they become unreasonable. I agree with most that this is out of hand, but on the other side, they need more data than whatever the short period the FDA needs. They may need 5-year, 10-year, but we have that now in cervical disc arthroplasty. So, but in general, the insurance company is misaligned in terms of the incentives. They have misaligned incentives. But back to the transition to cervical discs. So this is 20 years now. We've been doing cervical artificial discs. And cervical artificial discs, disc arthroplasty in the neck, has data that fusion will never earn. Never. Less adjacent segment degeneration, less reoperations, and patients objectively move and feel better. Okay? Lumbar's starting to gain that momentum. Lumbar's gaining that momentum. 3 spines work with MOTUS. Okay? Now we have we're load sharing device that restores sagittal motion. Physiologic biomechanics are precise. And for the first time, we have a device that respects the biomechanical function of the spine without overriding it, without changing it, without overriding it, right? That's fantastic. So I'm excited about that because for a lot of other reasons, you have a posterior approach. It's a total joint replacement. You get to decompress and stabilize and restore the biomechanical function and without punishing the other levels. So, but when lumbar fusions started out, it was all posterior work, right? It was big screws, rods. Then came inner body, attention to the anterior column, restoring height is always a big thing. It was good. And I stepped into my practice in Spokane, and it was stepped into a group that was it was a group, and it was really it was a traditional no fusion, all decompression, and there were people that had decompression after decompression after decompression after decompression. That was difficult. Redoing that was tough. Anterior lumbar fusions took off. The BAK cage, actually, the inventor of that BAK cage, George Bagby, is from Spokane, Washington, right near here. I got a story about him. One time when I was, and he's passed as well, but I was excited to meet him. He called me, and I was a new kid in town, and he was getting an honorary entrance into some international society, and for that he had to do some mundane administrative work that required answering some questions that were much, they're much newer than when he last studied. I show up at this restaurant in Spokane, Clinker Dagger, and there's this guy, and I'm looking for this guy that I know loves beer and plays banjo and just super cool. And there's George sitting there, and he's got this stack of books, and he's like, "Jeff, let me ask you some questions." And I just said, "George, I just want to talk to you, man. Let me have these. Give me the test. I'll give you this back later. This will be delivered to you tomorrow. This will be delivered to you tomorrow." But these anterior cages took off, and they still are. The anterior, and we now can get to the anterior spine from the front, from the side, and actually from the back by the posterior approach to get to the anterior portion, region of the spine. Yeah, I've been watching this, but that's what I mean. The complexity has just increased. It's been made so difficult, and it really has. Sadly, I mean, there's a lot of surgeons that are still fusion hammers out there, and there's new doctors out there, new surgeons out there. Fusion is not bad. Okay, overfusion is bad. Overfusion is bad, and being labeled a fusion surgeon, that is not a badge of honor. Okay, that is a lack of ingenuity and a lack of creativity. So you do not want to be just that. I mean, I say that, and I've got fusions lined up for. But here's an example. A guy's sitting in a bed out of town. He's going to come up here to have a fusion to stabilize a burst fracture. Okay, there you go. Or maybe there's something that's entirely unstable that needs to be fused. Okay, but now you look what's creeping down the road, MOTUS, right? There you go.
I think it's such a good point because fusion will have a place, right? And always will have a place. You talk about these, deformity constructs and tumor and trauma, right? Like there's a need for stabilization in those cases. But I think the point that you bring up, which I think is essential, is adding the tools that you have available, right? And I think that's super, super important because I think in cervical discs, right, we have, about 10 cervical discs on the market. They've gained pretty good traction. Lumbar discs are getting there, right? And are getting more traction, but it's adding more to that, right? Like you talk about MOTUS and going through the clinical studies and still collecting data, but we're looking forward to what's next, right? And I think we're at that really exciting phase where, and I'd like you to talk about this too, is you start to talk about adding approaches into that too, right? And adding minimally invasive surgeries into that. I think they all come together that complement each other, right?
Sure. Yeah. So minimally invasive spine surgery is it's not a definition per se. And I'll start out by saying it's like a surgeon that would be less invasive, more minimally invasive than me would be somebody that does pure endoscopic surgery. Okay. But I think my approaches are muscle sparing, they're transtubular, they're respect to the surroundings, trying to do the right operation, not the biggest one, right? But minimally invasive, when somebody advertises as a minimally invasive surgeon, I mean, there's some buyer beware out there for all of us. We all need a reality check. Okay, minimally invasive for you may be that you're now using a robot instead of taking your big opening and spreading it out like this to put in your 12 screws. You're using, you're making your big opening and just opening it a little bit and still putting in your screws like this. Okay, there's a minimally, but yeah, my approach has always been, minimal. I do probably 95% of my surgeries in the outpatient surgery center, and that includes lumbar fusions, it includes cervical fusions, it includes cervical disc arthroplasty. I would love to learn how to do my lumbar disc arthroplasties in my surgery center. However, this is an administrative thing where that code is limited to the hospital. So those patients go to the hospital, and that's another, probably some lobbying BS that, you got to deal with. But anyhow, but yeah, yes, the need when you're doing surgery in a surgery center, you have to be less invasive. You don't have the, you're more meticulous. There's no bleeding. There's no, you're just, not that you shouldn't be elsewhere, but you don't have mommy or daddy behind you kind of watching, right? You're doing this, you're on your own, and you got to take care of things. Yeah.
I'd like to talk to the patients too. You're someone does so many cervical disc arthroplasties. And when you're going down that path, or a patient that's searching for that, how do you delineate between, right? You said you're always looking for a reason to do a disc replacement or to retain that function and motion. How do you go about making that decision?
I see this all the time now, and this is probably the biggest area. Well, this is what there's going to be more. We're more permissive. The criteria for disc arthroplasty in the neck, for example, it used to be single level, soft disc herniation, radiculopathy, young patient. We become more permissive, and that's from learning. Now, myelopathy, that's fine. Bony compression. If your bony abnormality is limited to the disc space and not the facets, in my book, others may push it beyond that. But if your bony abnormality, if your arthritis, if you will, if your bone spurring is at the discs and even going into the uncovertebral joints, then you're a candidate. I will go in there with intention to do the disc arthroplasty and very, very, very rarely not be able to get that done. Where don't I get it done? If it's like there's just no opening. Those uncinate joints are actually fused together. The uncinate joints being the joints that wing off of the disc. Now, in most cases, We do what's called a reanimation. You can get in there, you can mobilize this, you can do a little resurfacing of those uncinate joints, if you will. Take a large footprint disc if you do that, and you use a large footprint disc. And they come out there now for bigger footprints, 20 wides, 18 deeps. You can fill the space and still get the center of rotation where you want it. Lots of, as you said, there's 10 different discs out there you can choose from. Well, actually not choose from, but probably 7 you can. So, yeah.
What do you use for your discs, and what are you looking for in those discs? Do you change it based on patient pathology? Because I assume you use we hear a lot of surgeons that use a couple different cervical discs depending on what they're looking for, the pathology they're trying to treat, and the functionality.
I stay on label. Okay, I stay on label just because I'm not treating Hollywood here. Okay, in general, maybe there's a little bit of that, but there's not. I'm treating this community largely, and people coming, that come here, and it's they're still controlled ultimately by insurance. I'll fight to get it done, but I will use, for example, I'm doing a multi-level disc arthroplasty. We're limited to 3 different discs. Okay, now I guess 4 now. We have 4. Yep. Pro Discs just made it into there. I'm very thankful for that. Pro Disc is kind of one of the OGs, and they remain that way. They really do. So those guys have done a great job. Offer 4 different cervicals, 3 different cervicals, and a lumbar. That's very, very well done. These guys have put together a good package, and so it's hard not to find a fit for a patient. Yeah.
It's got to be exciting as a spine surgeon to have.
It really is.
Yeah,
it's a good time. It's
super.
Lots of tools there.
Yeah, that's exciting. So when you're going through this, and when patients are going through this, you brought up a point yesterday that I really, really loved, and you talked about how big of a role conservative care plays, or pre-surgery plays in getting through the care continuum. When you're a patient and you're going through that, when do you decide that it is time? How do you figure out for surgery? How do you figure out that it's time when you're not waiting too long, you're not giving up too much? When is it time to go in and do that?
There was a scoliosis surgeon that moved from Washington to Seattle. His name was Dr. King. He went from Washington to Idaho. And when I moved here, he was sort of the go-to guy. He's a scoliosis surgeon. It's like the classification system's named after him, and he was practicing in Boise, Idaho. And when I'd see patients that had these curves in their back, and let's say you got this curve in your back, but you have a pinched nerve. You find that you have this curve because you've got an L4 radiculopathy, because at the apex of this convexity, this nerve is getting the Jesus squeezed out of it, right, as it's going through. And I'm like, okay, I'm going to these meetings that are, there's a lot of industry-driven stuff. You go to some of these meetings and you can fog a mirror. They'll show you how to fuse an SI joint, right? But you sorry, Cord, if I called Dr. King. Hey, Dr. King, I got this patient. He's got a foraminotomy, but look at this pretzel. Like, Jeff, he said this. It was so meaningful to me. He said, Jeff, it's okay, man. Don't be afraid to be the index surgeon, the so-called index surgeon. Go ahead, decompress that nerve root. And if, everything goes haywire because of that, you so-called index surgeon, right? Then, well, I can fix it. But for right now, just fix this. I've got an NHL referee that looks like that out there. He's out there blowing the whistle. Yeah. With a spine that if he got a hold of, some guys got a hold of him, he'd be a presentation at a meeting with rods from here to there, right? You can get him through. Wabi sabi. I think the translation amounts to, in Japanese, rust is okay. You take a 1970s Honda motorcycle. We talked about this. It's going to live longer than what they're producing today. Maybe a Ducati or something last, right? Because they got this to it, but rust is okay. So if you take a spine that is degenerative, and it's okay. You don't have to fix that picture. You don't have to. You can try to get by. You can, but at the same time, I think being proactive on motion preservation is important. So if there is something you need to do to push down that line, and you can make that decision. You just make it soundly. Be thoughtful in your decision on when to do that operation.
You brought up the point of being a presentation at a meeting. We've obviously seen plenty of those, and you used your radiographs as your presentation for what everything looks like. you talked about this a little bit yesterday, and we actually saw a couple of your patients come through and,
Oh, you
talk
want
to you.
to
It was
examine,
amazing.
right? Yeah. So
Yeah. It's amazing. Can you talk about too, like the importance of following patients post-operatively? Because you talk about that and how important that is in the success outcome of surgery, right? It's not just the radiograph post-operation. It is everything else too, right?
Yeah. Well, you happened to come in and check out the office yesterday on a Thursday, and I operate on Wednesday. Patients go stay in a hotel. They come to the office, and you saw it. I mean, they come in, it's how you doing, and everything. Say hi to Oliver, do whatever. If they have a drain, check it out. Give them instructions, and then they're off and running. But this is important, actually. Following you, as I said, patients, I think, will see. Well, my patients, I think, one of the reasons they seek me out is because I treat them individually, and there's no algorithm. It's not like you're going to get this, then you're going to get this, then you're going to get this, and then you're going to get this. It's not that path, right? It's very thoughtful. That's part of the philosophy. Okay. I keep a close eye on them. Part of that started with Idaho workers' compensation is a very strong program. When I moved here, I get a lot of injured workers. These are deadliest catch guys. I mean, these are loggers and stuff like this, right? They didn't just tweak their back at some meeting, right? So not that it isn't a bad deal too. Okay, look at you smiling.
I was just going to say, I was like, wait a second, that could be me though.
Yeah, that could be you, right? Yeah. So in fact, this is good. This is good. When this would have been about 2007. I mean, right when us, the Gen Pop, were allowed to start using artificial discs, right? I had a guy that came in. This is a kid. Yeah, you say kid. He's what, 30, 20, late 20s, maybe 30. And he was teaching. He was a teacher, and he had a day trip with his kids to come snowboarding up at the Schweitzer Mountain, just north of here. And he wiped out on his snowboard, and he took out. He hit his shoulder, and the entire focus was on his shoulder for a year. And this was ski season, right? So he blows through summer. He's not doing anything that he likes to do, and he's a real colorful guy, man. He's just so funny. And what happened? How did this work out? He came in to me in November carrying a brand new snowboard. That was his karma. I was going to tell him everything was okay. The reason he came in was because after months of working on his shoulder, they did an MRI of his neck, and he had a C6-7 disc herniation with a C7 radiculopathy. Period. At this time, the FDA-approved disc was Prestige from Medtronic. Okay, and I said to him, Nick, man, you need a surgery, and he's just crushed. He's crushed. He's like, but listen. Disc arthroplasty is here, and I will push for you to get this done. So he was an injured worker in Idaho. And I asked them, I said, I will do it for you as soon as we get it done, and I will see you regularly. We'll get you on your board. You will ski. You'll board this winter. And that was before I'd ever done an artificial disc. No, I had done some. I'm sorry, when I first worked comp one here. Okay. I had done some. So I knew already that people are going to get back quick to their activity. That's the beauty of it. It really is one of the beauties of it. So Nick comes in. He agrees to this, but he's still crushed. Talk to the Idaho work comp program, and they say, okay, Jeff, we've not done an artificial disc yet. You're under the microscope. You're our first one. You're going to do it. And it's approved. Well, they approved it on December 22nd. And Nick's so Holly and I, I'm a nurse practitioner. You should remember this. It was December 24th, Christmas Eve. I held true to I promised him as soon as it got approved. Christmas Eve, did his disc. And, this was Prestige, which was owned by Medtronic, right? If you can find it, there's a video out there. They made a video of Nick. They're up at Schweitzer, and it's super funny to watch Nick. And Nick is a radiology tech in Kansas now. And hey, Nick. And he's still, hey, I'm loving my thing. It's good. So, but what came from that was, as I said, work comp was watching this. So he went well. How perfect to have this guy that was just going right back to it, right? How good was he for the next one? How good was he for the next one? And the next one, and the next one, and the next one. And so ultimately, after a couple of years, I had my office pull the code for disc arthroplasty. At that time, it was only single level, right? And for cervical fusion in work comp patients. Okay. And so what we found was that in all of these patients, the neurosurgical problem resolves in all of them, the radiculopathy or the myelopathy. At that time, it was mostly radiculopathy because remember, we were more conservative in what we were treating. Weren't getting into myelopathy yet. Everybody, was that, I mean, honestly, subjectively and objectively, they were better. All of them went back to work. And the difference was this, it was striking. This is a retrospective look. And it was that the return to work for a single level artificial disc on these patients, which again, loggers, guys wiping on their snowboard, 28 days.
Wow.
Okay, in my hands. For cervical fusion single level, 72 days, 71 or 72 days. Okay. And I had pulled 2-level cervical fusions as well. And I need to do this again now over like 20 years, right? I really will do that. That'd be a great one to do. Need a student? Okay. Yeah. So anyhow, it'll be a great one to do. If for 2-level cervical fusion, it was 120 days. And I'm aggressive on that. I mean, I push, I'm going to say aggressive. I pay attention. So I think it's very common to be an algorithm. And I'd advise you guys, if you're developing your program, if you're new into this, I'm going to see you at 6 weeks. I'm going to see you at 12 weeks. I'm going to see you at 18 weeks. I'm going to see you at 6. Life is motion, man. It's happening daily. So I would see these patients maybe at 2 weeks, 6, and really be on it and measuring and doing this. And every step of the way being involved in they're giving them their life back with the least surgical burden possible. So that worked out well because now cervical disc arthroplasty, and now I'm seeing all the time patients that is disc arthroplasty an option? In my community, is disc arthroplasty an option? I've been told I need a fusion.
I think it's such an important point. You brought up the story with Nick, and when you said
you got to watch the video. Watch Nick. It's a Medtronic video from about, I bet they did around 2010, something like that. I don't know. Nick. He's great. He's so fun to watch. He's snowboarding through the woods. So like he's starting, and there's Nick, and they got their film crew like this, and they're looking up there, and then the crew would yell ready, and Nick would yell, "Wrap in," and he'd like click something, and then he becomes swooshing through on the snowboard. It was fun.
So awesome. We'll see if we can find that. Our listeners, I'm sure, would love to see something like that on a patient story. But when he comes in and you talk about the story of patient coming in, you saying you're going to need another surgery, and that feeling of just being crushed and hopeless. Do you have patients, because I'm sure you see this all the time, we're seeing more patients that are willing to travel for care and go seek out these motion preserving, functional preserving surgeries. Do you get a difference in reactions from patients when you tell them that they're going to have to get a fusion versus getting a disc replacement? Are there patients coming asking for disc replacement? What's that been like, especially over the last 25 years have you been practicing here?
I think it's what I deal with regularly, and what's become a very commonplace is a patient comes having been through everything, so-called been through everything. And, what's our tag? The mind that diagnoses you and the hands that heal you, right? So listen, this diagnostic ability is important, and I pride myself on making the correct diagnosis. So I get it. You had 9 injections, and you had this study done. The fact that I want you to do another injection, in fact, I'll do it for you. I will do it for you, a diagnostic injection, okay, for you. But I want to know exactly where the pain, precisely where the pain generator is. What am I treating, and then carve out the proper thing. And sometimes it is fusion, sometimes it is, but it's not over fusion. Period. Is that?
Talking about all that, and you keep talking about, it's a lot of times we can just be stuck in our box, and this is how I treat, this is how I see the world. And I love that you're more expansive. You're like, it doesn't all just fit in this, especially with a patient. I think the Nick story is really interesting because he spent months and months just working on his shoulder, but it was a cervical problem the whole time because we're a linkage system.
Yeah.
And you can sometimes be treating something because your pain is somewhere else, but it's coming from a different place. How do you pull out for your patients like that and look at the body holistically when you are determining how to treat? Because I think a lot of patients, they don't know, and they're just like, my arm hurts. right? Or like, I have pain in my butt down my leg. They don't realize it's coming from their lower back. How do you educate or like kind of pull yourself out to look at the patient holistically?
Okay, as a doctor, you're going to have a moment with the patient. And you can decide, you get to be the one generally that decides, is that moment going to be 5 seconds? Is it going to be over the phone? Is it going to be 10 seconds? Is it going to be 30 minutes? You can decide what kind of relationship you're going to have. But in that process, you're going to get to know the patient. You're going to know, you're going to examine them. I mean, I work with a nurse practitioner in the office and one in the operating room. In the office, Holly she can pick out a nerve being picked off in a lateral recess, that is called normal or minimal or not read on the MRI or, something like that. But part of that is just watching the kinematics of the patient, watching them walk. Your body is subconsciously going to do two things. It's going to balance your head over your pelvis, and you're going to seek horizontal gaze, period. And if you're off on your foot strength, if you have a foot drop, you need to have 6 degrees of motion, of 6 degrees of dorsiflexion in your foot to clear. If you don't have that, you're going to start swinging your leg. You're going to start swinging your leg. And a big time orthopedic surgeon in Seattle, Jens Chapman, told me. He said, and I listened to everything people tell me. Okay, I'll decide whether I'm going to use it or not. Jen said, never do a lumbar fusion in somebody who has tight psoas muscles, because you're just pulling it in. So, that's something there. Prehabilitation is big. I know, in Salt Lake City, Armin. And, Robert. Robert. So prehabilitation, these guys prehabilitate their patients, and that's great. So physical therapy, patients don't want to go. They've been there, they've done it. It's hard, Courtney. It's hard, but I'm like, look, you're here. It's just like when you go to you're here. You need to, I want you to trust me on this. I'm not going to waste your time, but I'm not going to be pushed into do something inappropriate for you, because it'll look good on an X-ray at a meeting.
If you're a patient and you're going through this and you're looking for functional preservation, maybe that's an implant, maybe it's not, it could be surgery. How do you seek out that surgeon? What are the questions that you should be asking if you're going to look for a motion preserving surgeon or a surgery?
Yeah.
What are you looking for?
That's really important. It's dangerous out there. Patients don't know. It's scary. There's a lot of Kool-Aid out there. So look, you mentioned the social media presence and all of this. I speak authentically. I speak, this is true, but that's not peer. There's no peer reviews on that. Okay? There's no peer. So you can't trust me because of what I say on social media. Okay? You can trust me for other reasons, right? And you can look at the whole picture. But there's a lot of vehicles out there. There's no ways to get another opinion. I see on the people you're interviewing. I mean, these are guys. These are quality guys. They could have been captain of the Harvard crew, right? And they're out there offering to look at your MRI to see this. So do that. Get another opinion and just ask the question: are there alternatives to blank? So that's probably the most important.
Well, I think it goes back to what you said earlier, which is you've got to be the CEO of your own healthcare.
If you're not, then you're going to end up in a system.
But it's hard,
And
especially.
the system is disease care, as we know. It's not healthcare. So,
but it is hard for patients because there is a lot of misinformation out there. And I love what you said about you can trust me for other things, not what I say on social media, or take that and then go, cross-check that information, go and find sources. Like, don't just take one thing that one person says. And then the same thing goes for getting a second opinion. Most of the guys we sit down with say, you should get a second opinion. Even if like I'm going to do treatment on you, it's great just to get another opinion because there's multiple ways to do the same thing.
What I love too in the second opinions is what happens is typically in my scene, Holly might see the patient first. I try not to look at the imaging ahead of time, but it's kind of hard now because now I don't want to waste patients' times. And you're right, sometimes they're coming from away. So I look at Michaela, my front desk, and I sit down with every single patient that comes in, and we kind of look at the films to decide, do they need our help? Do they need help, or do they need something else? That's it. And it's not always surgical, right? I mean, do they need our help? Should we be seeing them? And sometimes, I mean, I applaud Dr. Landman on his charity cases, he calls them. I get this, it's the same. And often it's, it's since I'm out of network and uncontracted, that includes the VA, right? And this is, I typically try to look for that guy that is destined for a fusion. And otherwise I'm like, okay, I got to step in. I want to step in. I want to meet you. I want to see you. It's not going to cost you anything. I'm going to see you. I want to look at you. It's not, I'm going to figure out every I'm not a chronic pain doctor, period, But yeah, when I go in, as a second opinion, I like to not know what the first guy said.
Yeah.
I mean, so you can sometimes though, now I say in this town, I'll be like, don't tell me who you saw, right? Do not tell me who you saw, because you get to know in your town, who are those guys?
You do so much work, to talk about one of the pieces that we were just talking about here on the education side. You do so much, you put so much content out there, almost 10,000 followers on TikTok, which is incredible, right? You've built this huge following and you build all this for patients. You're on Instagram, you're on LinkedIn. Did you always want to do the education piece? Do you like that mentorship? Like, what made you get on and do that? Because you're busy enough as it is. It's a lot of work to continue to do that.
I mean, even when I'm doing an independent medical examination for something, I tell the patient, listen, I'm not your doctor. I'm hired by somebody to answer questions about causation, about care, and about what should be done, or where is it closed. But I'm going to think out loud. I'm not answering you. I'm going to think. You're going to hear a consult. So here we go. But it's just the in the interest of what we do. And I've had so much education, and these are traits you learn from your father, from your mentors. John too is one of them, and he's I got together with him last month. I'm going to see him again next month. I'm totally stoked for that. So.
Well, I think that's what's so great about your videos that you post on social too. It's really a behind the curtain. Like a lot of your videos, you're sitting, you're showing the image, and you're taking the patient into the aspect they often don't get to see. And so it's digestible in a way that they can understand it. And you're also getting the education of like understanding what goes into making decisions and pathologies and all of that, where you don't often see, it's, especially, patients can sometimes like have 5 minutes. The surgeon gets to decide, or however the practice is set. Like you said, am I going to give 5 minutes? Am I going to give 45 minutes? How am I going to have this this connection with the patient?
Yeah, it's mutual though. It's for the future. If you enjoy it, and you'll be part. You have to. It works out for both the patient and the doctor. So
I agree, but I think it's just so great for that misinformation, or just being a patient, being able to better understand the complexity that is spine care, and working on simplifying it. It's really cool how you set up those videos.
At the end of the day, that's the goal, is the art of spine surgery. Make it just like the art that I witnessed Dr. Larson do for my friend earlier this week. Neurosurgical simplicity.
You make it accessible too, right? Like you're truly on there interacting with patients, right? You pull out comments and you will interact and answer questions that are out there.
Now that's Bree. Okay, so I will do this. She's sort of figures out what I should. I mean, hey, Jeff, these guys want to know this. I just, for example, apparently there's somebody, and by the way, there's a shout out to Scrub Techs. I didn't do it. I had a chance yesterday. I took a plate out of a Scrub Tech. So a Scrub Tech had 2 fusions, sadly, in her neck, and she was getting some adjacent segment degeneration to that. And now the plates, you can cause that. And she had some dysphagia, so it just wasn't for that. But I took the plate out in hopes that she would slow this down. Now, let me talk about this case for a second, because it's important in an example of where we are in the insurance and what we have to work with if for the people that are, writing the checks for the patient's healthcare, right? Today, in 2025, almost 2026, there's a surgery that can be very viable. It's called a hybrid. It's where you fuse one segment, do an artificial disc next to it. Or maybe somebody's had a fusion and they blow out the other disc. and you do an artificial disc. Commercial insurance does not recognize that. If they do, please call me and tell me. But in my world, they do not recognize that. So, yes, shame on them, okay? But shame on the fusion surgeon who took this young woman in 2018 and said, I don't believe in artificial discs, and did a fusion because he set her up for this cascade. Now I can't get around it, commercially insured, but we'll figure it out if she needs to have this other disc done. But yeah. So anyhow, I missed the opportunity to say thank you to scrub techs because our system is really, it's important in the OR for everything to be proper. I mean, think about it. You're focused, in my case, under the microscope. You're being handed, you're going, it's a system and it's very predictable. Dr. Armin's, one of his partners, developed this technology, XX. It's called. It's basically, it's augmented reality in the OR where the surgical tech has your entire surgery mapped out in his glasses looking at this. And so he's going to know when it's time to hand you the curette, know when it's time to hand you the pituitary, know when it's time to hand you the trial, the keel, the disc. I gave away my favorite disc there. He's going to, well, one of my favorites. So one of my discs. Actually, a couple have those now, right?
Yeah.
Yeah.
Yep.
But yeah, so thank you, Dex.
I think that's
No,
a
they are
part.
important.
I was going to say, and that's a
Yeah.
part that the patients don't see too, right? Because you talk about all this stuff. It's not about just being handed the right instrument. It's about being handed the right instrument at the right time in the right orientation, right? Because you're
Absolutely.
not looking up. You just put your hand out and make sure that the right instrument falls in it.
Yeah.
And so a good scrub tech, and not, the scrub tech obviously is huge, but everybody in the OR, I mean, that is, you have to create a well-oiled machine to be up for that to go in the right direction.
I have a close friend now, Ted and Tiffany, and I don't think I'm violating HIPAA with our first names. Probably not, right? Yeah, okay. So I get a call from Ted, and he's concerned because his wife's getting numbness in her hands. Okay, and they were overseas. They were in Croatia, and I said, just tell her, dive feet first. I'll check it out later. Who'd have thunk that this, vibrant, young, athletic person was going to have cervical spondylosis at 2 levels with kyphosis and compression of the spinal cord? Okay, who's done that? Well, she did. And I'm bringing this up for not meeting the techs and stuff, but and it ended up that I had to get her approved for a 2-level disc arthroplasty in the face of spondylosis. So that was a hurdle with her insurance. More permissive. It's not a soft disc. It's not 1 level. It's spondylosis. It's kyphosis. It's these things. B, get it done. And there's a technique if you're going to, as I said, they don't allow hybrids. So you could do like fusion at 1 level, artificial disc at the other, possibly, as a bona fide treatment, but they don't allow that. And ultimately, I was able to reanimate that spine, put the 2 discs in, and I literally within 6 weeks, I think she was in Cabo singing "Sweet Child of Mine" on a stage, literally, and that which made me feel good that the vocal cords weren't messed up. And then running and doing everything. I mean, they happened to visit. They became friends, and they are friends. And they visited during our surgery center Christmas parties tomorrow night. They came to it, and they wanted to thank everybody. And it's big, it goes. It's a team. It's a big team.
And when it's done right, it really is like a symphony, right? Like it's
Absolutely.
all has to play together.
Well said.
So well, and like that. You can only do your job the best you can when everyone else around you is playing the symphony in the right way and in the right tune.
All
and
instruments,
it makes such a
Courtney, you
difference.
nailed it with that. It's absolutely a symphony that has to be well tuned in each piece.
Mm-hmm.
Each piece.
Well, you've got it together here. It sounds like you've got that
Yeah.
symphony
Keep-
here.
Keep learning. We
Yeah.
keep learning, right?
Yeah.
Never stop learning. Never stop exploring.
That's amazing.
We're in Idaho.
Yeah, exactly right.
Let's go
That's the place-
explore.
yeah. But you had brought up Dr. Robert Masson and him being an innovator. We've sat down with so many surgeons that are inventors and innovators, as you yourself are, and you've actually have had products that have been acquired. You go back to Synthes in 2006, and you had a product with Stryker in 2017. What is it that you innovate on? What makes you want to do that? Get out and create. Operating and learning how to operate correctly and improve on that is a big enough task in itself, right? But to go out and to create these systems that get acquired, one, they're worthwhile and provide value. But what is it in you that sees that and is able to build and create and innovate?
I think, I like to draw. Okay. And then and we talked about it, Dr. Lawton coming out and just in 30 seconds drawing out this operation with a marking pen, right? And just there it is, right? And it used to be that in intellectual properties, that prior art or art would include what you drew if it was bound and signed. Now it's different. It's got to be filed somehow, administratively filed. But it used to be that. So I have these books and books and books of of artwork, and it's a continuous process. It's everything. Hopefully, will find its time. And we bring up. I think I was telling a story how I'm sitting at a meeting at one of the motion meetings, and there was a lunchtime talk going on from one of the companies talking about sagittal balance in the neck, and I'm kind of getting my free lunch and listening, and all of a sudden, it was Landman.
Dr. Todd
Todd,
Landman.
Dr.
Yep.
Todd. Thank you, Todd. He's up there and he mentions that in cervical decompression, and Todd, listen to this. This is true. I'm so glad about this. That in each case, he takes the time to at least prepare, if not resect, the medial uncinate joints. And that's important. It really is important for mobility. And there's some white knuckles in that because you're getting near the vertebral artery, but come on, you know where it is, and just deal with this, okay? So he talks about the uncinate joint, and I hear uncinate joint because I had this artwork written up on uncinate joints, everything. That was one of my ideas of where motion preservation could happen in lieu of an artificial disc or a salvage of a failed fusion could happen there. So he lit this up, and at that point, I'd never heard someone say uncinate joint other than me on my books. And then all of a sudden, it was some of the other legends in neurosurgery, Dr. Pimenta and Dr. McAfee. All of a sudden, they took over the room, and everybody's resecting uncinate joints. So I went home, and I went to town, and I pulled those books off the shelf, and I just put them in. And now we have an implant out there that involves the uncinate joints, which makes sense if you look at it. Yeah, it's a little more intimidating to look at, but the uncinate joints are the strong part of the spine. So you just think like this, and those those who have been licensed those IPs will realize about the motion preservation aspects of those uncinate joints as well. So
it's amazing. You talk about you being an innovator and a creator. You've been doing.
You talked about it. I didn't.
We talked about, and we know that you're an innovator and a creator, but you've been doing this for a long, long time. You've been practicing for 30 years. What do you think's the biggest change that has improved spine care over that time? Because we've had so much change. You talk about like kind of the fusion, merging to motion preservation, and all these technologies. What is it for you that's impacted the most?
Well, I think it's the stamina of the surgeons really that have guided this in hospitals, those painful meetings at hospitals, those meetings with corporate, those long, if the complications with patients, the stamina of the surgeons and these teams that have done it. So applauds to all of you, all of us that have kind of kept this going, because there's not one thing. I remember when I was taking fusions to the outpatient surgery center, we all develop our sort of way, right? And it would be, I think Mike Wang got hold of that I was doing T-lifts, and this was way back, and he took me aside at one of his meetings and said, "What's going on, bro? How are you doing this?" Because he was at that time going to do them awake. Anesthesia was a thing. It was he was going to kind of convert to this awake one, and we all just sort of push each other and know each other and talk to each other, and it's important. It's very important to communicate and share. It needs to be open science like that. It shouldn't be when you sit here and somebody's got their proprietary shit they're doing, right? Their thing that that they can't bleep, so that they can't do. That's a buyer beware. Okay, open science is the great. I was hell skiing up in the Shugach, and I was stoked, and I love coffee, and I'm up early in the morning. Okay, I'm up early in the morning. I go to the coffee machine, and then there's the guy sitting there from the East Coast. He's just changed jobs from Janssen Pharmaceuticals to the NIH. He's a lawyer, and he'd never skied powder, and he was on a board, and that's miserable. I'm like, what are you doing here? I do not want to be in your helicopter, because this is, but anyhow, we're talking, and he said his drug that he had at Janssen was for cystic fibrosis. When I was in my residency, that demise was in high school for cystic fibrosis. Okay, that has tripled, quadrupled. to far more normal lifespans. And he explained that the reason that was the industry as a whole agreed that this was going to be open science. If somebody figured something out, they weren't going to compete at the science. They weren't going to compete. They were going to compete at the molecule. So let's do it in spine. Okay, here's the device. I mean, the perfect motion preservation device probably isn't out there because of all the patents that don't work together, right? Somebody's got this and somebody's got this and somebody's got this, but they're good. But anyhow, working together that's one of the best things about I think in neurosurgery. I love it. We really have. I've got on my phone my neurosurgery oracles. So if I'm doing a consult and something I don't understand, I take a picture, send it. It goes to Chicago. It goes to Mayo. It goes to, now it's going to go to Barrow. It goes to Cincinnati. It goes to Eugene, and I'll get an answer because these are my buds that are saying, it's this, here's how I do it. So it's really the second, third, fourth opinions right there.
As you look back, we appreciate, this is amazing that you host us and all the time that you've given us. What are you most excited about looking forward? Because you still have plenty of healthy years to be out there operating.
Yeah,
what are you most
right.
excited about moving forward for patient care and improving patient care?
Gosh, I've been just hitting singles, and I like it. Just get on base and keep it going, and I can do what I'm doing for a long time. And I'm very thankful to have the health and wherewithal to do that, and the skill set that I've been given to do that. So I embrace it. I'm not I watch technologies come and go, and I absorb them into my practice. If I'd use them on myself, really, and I'm having a really good time doing it.
Well, we're grateful to sit down with surgeons like yourself. I mean, this is
awesome.
truly impressive. It's so helpful for patients to be able to hear this too. And the education and the story, you do a little bit of everything. You're an athlete, you're a surgeon, you're a father, you're a social media star. It's truly impressive. But for the patients that are looking for you, where can they come find you? Obviously, you've got the TikTok, you've got Instagram. Where can they find you? Where's the best place to reach out?
Now you can, if you go to the website, CDA Spine. Okay, if you go there, there's a load images on top.
Great.
And then this is a great little deal here. You basically go on there. It'll tell you how to load your images. If you don't have what is necessary, you press a button and it'll show up at your door via Amazon, probably something. It gets loaded, and you just follow the instructions, call. Ultimately, we're going to have contact. So you call Michaela, and we'll get the ball rolling. That's probably the easiest. You can, if you are in, if I haven't responded to your messaging or your TikToking, then it's Bree who you should take that up with. I've tried.
Then it's not you.
Yeah.
Well,
And your CDA Spine on Instagram.
I think
and
everything.
TikTok.
I think everything.
Definitely got to check those
CDA
out
Spine.
too.
Yeah.
yeah, and we'll link all that.
Yeah,
I think we resonate with so much of what you do and your care perspective and the way that you approach patients and patient care. And I think Courtney summed it up very well about this symphony. And I think it's really nice to see here because we see everything that you've done and the improvement that you can make in patients' lives, but we see the orchestra around you as well, right? And so we got to sit down with you, and we got to meet Holly, and we got to meet Meigs and Bree, who's running everything behind the scenes, right?
I think and Lisa connected us. There's so many times I get these calls, and she said, "You got to talk to these guys. This is cool." And so I looked and then saw your lineup. I'm like, "Yeah, let's do this." I'd be honored to be on your lineup. So.
No, well, it's fantastic, and it's amazing to see everything that happens behind the scenes and the incredible people that you're surrounded by. So we're grateful for it. We appreciate you taking all the time,
My
and
pleasure.
your team taking the time as well. So thank you so much for sitting down with us.
You betcha.
Thanks for
Let's have a
listening.
croissant.
Let's do it.
All right, thanks, Dr. Larson.
All right.
We'll talk soon.
You betcha.
Bye.
Take care. Thank you.